For decades, hospitals have closely monitored readmission rates as a key quality metric, understanding that fewer readmissions mean better outcomes for patients and lower resource utilization. During the height of the COVID-19 pandemic, hospital capacities became overwhelmed and resources stretched thin, increasing the importance of hospital efficiency. While the burden of COVID-19 has lessened in recent years, I believe improving time to discharge and reducing the likelihood of readmission remain crucial to providing quality care for patients and supporting our institutions. Hello, my name is Stephen Deitelzweig. I'm a board-certified hospitalist at Ochsner Medical Center in New Orleans, and today I'd like to talk to you about the impact that VEKLURY, remdesivir 100 milligrams, has on recovery time and readmission rates. VEKLURY is an antiviral medication indicated for the treatment of COVID-19 in adults and pediatric patients less than 18 years of age weighing at least 1.5 kilograms who are hospitalized or not hospitalized, have mild to moderate COVID-19, and are at high risk for progression to severe COVID-19, including hospitalization or death. VEKLURY is contraindicated in patients with a history of clinically significant hypersensitivity reactions to VEKLURY or any of its components. Now, let's begin by discussing Act 1, the pivotal inpatient clinical trial that evaluated recovery time and supported the FDA approval for VEKLURY. Act 1 was a randomized, double-blind trial in adults hospitalized with mild, moderate, or severe COVID-19 who received either VEKLURY or placebo for up to 10 days. The primary endpoint was time to recovery within 29 days after randomization, based on an 8-point ordinal scale, and recovery was defined as no longer hospitalized or hospitalized but no longer requiring ongoing COVID-19 medical care. The results of the study showed that VEKLURY reduced recovery time by 5 days compared with placebo, with a decrease from a median 15 days to 10 days. In terms of safety, the frequency of adverse reactions were comparable between VEKLURY and placebo. While Act 1 results were released during the initial phases of the pandemic, they remain relevant to me as I apply these results to my clinical practice today. Reducing hospital readmission rates is another critical factor in overall patient care. It can negatively impact patients' experiences and well-being, increasing out-of-pocket expenses, strain limited healthcare resources, and increase the overall cost of care. COVID-19 is of particular interest due to its association with relatively high readmission rates. In 2022, the National Readmission Database reported 104,600 30-day all-cause readmissions for patients hospitalized for COVID-19 during their index stay. This was the fourth highest number of readmissions amongst index diagnoses in the United States and equates to about 15% readmission rates. To put that number in context, that means that 1 in 6 COVID-19 hospitalizations resulted in a 30-day all-cause readmission. The figures may have evolved since 2022, but in my experience, keeping readmission rates low remains significant to providers and hospitals. Keeping that in mind, let's discuss a real-world study evaluating the impact of VEKLURY on the likelihood for readmission. Before getting into those details, I'd like to remind you about a few general considerations with real-world studies. First, it's important to understand what datasets or methodologies were used to address confounding or bias. Next, you should consider how the study fits within the context of all available data and how it contributes to what's already known. Finally, results may vary, so it's critical to take other real-world evidence into account when applying these data. With these considerations in mind, let's review the study. This was a large, real-world, retrospective, observational study examining 30-day readmission to the same hospital after COVID-19 hospitalization in adults treated with VEKLURY versus those not treated with VEKLURY. It was conducted across variant periods from May 2020 to April 2022 and covered the pre-BA 4-5 period. The primary endpoints were 30-day COVID-19 related and all-cause readmission after being discharged alive from the index hospitalization for COVID-19. These data were examined using multivariate logistic regression model, which adjusted for age, corticosteroid use, variant period, Charlson Comorbidity Index, maximum oxygenation requirements, and ICU admission during COVID-19 hospitalization. Data for the study were obtained from the PINC-AI Healthcare Database, which is a U.S. hospital-based, service-level, all-payer database representing about a quarter of all U.S. hospitalizations. Approximately 248,000 VEKLURY patients were compared with approximately 191,000 non-VEKLURY patients. The patient population included a broad range of comorbidities, supplemental oxygen requirements, ages, and concomitant medications used. VEKLURY patients tended to be younger and more likely to have received some level of supplemental oxygen support compared with non-VEKLURY patients. Strengths of this study were that it included a large population that enabled subgroup analyses across variant periods and supplemental oxygen requirements. Also, it included a well-defined cohort of patients hospitalized for COVID-19, and this study complements the findings from randomized controlled trials and subsequent research over the evolution of the COVID-19 era. Limitations of the study included the potential for residual confounding due to unmeasured variables, including differences in groups that could not be accounted for. In addition, the database did not capture data relating to time from symptom onset, infecting viral lineages, and pre-hospital care, such as other treatments. Due to the absence of billing charges for supplemental oxygen, some patients who received supplemental oxygen could have been misclassified as no supplemental oxygen charges. Finally, patients readmitted to a different hospital were not accounted for. As for the results, VEKLURY reduced the likelihood of 30-day all-cause readmission to the same hospital by 27% compared with non-VEKLURY. A statistically significant reduction in the likelihood of 30-day all-cause hospital readmission was observed across all variant periods and all supplemental oxygen requirements, with the exception of IMV ECMO. But, as you can see, the IMV ECMO group had a low sample size, which may have contributed to this result. Looking more specifically, VEKLURY reduced the likelihood of 30-day COVID-19 related readmission by 40% compared with non-VEKLURY. A statistically significant reduction in the likelihood of 30-day COVID-19 related readmission was observed across all variant periods and all supplemental oxygen requirements. The data here, when viewed alongside other clinical trials, real-world evidence, and clinical guideline recommendations, led my hospital to include VEKLURY as a recommended treatment option within our inpatient COVID-19 protocol for patients regardless of oxygen requirements or days from symptom onset. And for me, VEKLURY remains foundational for COVID-19 inpatient management. Despite the evidence, according to a cross-sectional survey for 2023, some hospitals continue to restrict access to VEKLURY. From my experience, this practice can be the result of outdated inpatient protocols. So following this video, I would encourage you to educate your colleagues about these data and review your inpatient COVID-19 protocol and order set to ensure all eligible patients can access VEKLURY. With that, to summarize today's discussion. First, VEKLURY was shown to reduce recovery time. Second, VEKLURY significantly reduced the likelihood of 30-day all-cause and COVID-19 related readmissions, and put together with other evidence and guideline recommendations, VEKLURY should be considered a standard of care within inpatient COVID-19 protocols and order sets. To conclude, let's review some important safety information. Hypersensitivity, including infusion-related and anaphylactic reactions, have been observed during and following administration of VEKLURY. Most reactions occurred within 1 hour. Monitor patients during infusion and observe for at least 1 hour after infusion is complete for signs and symptoms of hypersensitivity as clinically appropriate. Symptoms may include hypotension, hypertension, tachycardia, bradycardia, hypoxia, fever, dyspnea, wheezing, angioedema, rash, nausea, diaphoresis, and shivering. Slower infusion rates of up to 120 minutes can potentially prevent these reactions. If a severe infusion-related hypersensitivity reaction occurs, immediately discontinue VEKLURY and initiate appropriate treatment. Transaminase elevations have been observed in healthy volunteers and in patients with COVID-19 who receive VEKLURY. These elevations have also been reported as a clinical feature of COVID-19. Perform hepatic laboratory testing in all patients. Consider discontinuing VEKLURY if ALT levels increase to greater than 10 times the upper limit of normal. Discontinue VEKLURY if ALT elevation is accompanied by signs or symptoms of liver inflammation. Co-administration of VEKLURY with chloroquine phosphate or hydroxychloroquine sulfate is not recommended based on data from cell culture experiments demonstrating potential antagonism, which may lead to a decrease in the antiviral activity of VEKLURY. The most common adverse reaction, greater than or equal to 5% all grades, was nausea. The most common lab abnormalities, greater than or equal to 5% all grades, were increases in ALT and AST. Administration should take place under conditions where management of severe hypersensitivity reactions, such as anaphylaxis, is possible. For patients who are hospitalized, VEKLURY should be initiated as soon as possible after diagnosis of symptomatic COVID-19. For patients who are hospitalized and do not require invasive mechanical ventilation and are ECMO, the recommended treatment duration is 5 days. If a patient does not demonstrate clinical improvement, treatment may be extended up to 5 additional days for a total treatment duration of up to 10 days. For patients who are hospitalized and require invasive mechanical ventilation and are ECMO, the recommended total treatment duration is 10 days. For patients who are not hospitalized, diagnosed with mild to moderate COVID-19 and are at high risk for progression to severe COVID-19, including hospitalization or death, the recommended total treatment duration is 3 days. VEKLURY should be initiated as soon as possible after diagnosis of symptomatic COVID-19 and within 7 days of symptom onset for outpatient use. Perform hepatic laboratory and prothrombin time testing prior to initiating VEKLURY and during use as clinically appropriate. No dosage adjustment of VEKLURY is recommended in patients with any degree of renal impairment, including patients on dialysis. VEKLURY may be administered without regard to the timing of dialysis. Available clinical trial data for VEKLURY in pregnant women have not identified a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes following second and third trimester exposure. There are insufficient data to evaluate the risk of VEKLURY exposure during the first trimester. Maternal and fetal risks are associated with untreated COVID-19 in pregnancy. VEKLURY can pass into breast milk. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for VEKLURY and any potential adverse effects on the breastfed child from VEKLURY or from an underlying maternal condition. Breastfeeding individuals with COVID-19 should follow practices according to clinical guidelines to avoid exposing the infant to COVID-19. To learn more about VEKLURY clinical trials and real-world evidence, please scan one of the QR codes here or visit the website at vekluryhcp.com. I appreciate you taking the time to watch this video.